or functional bowel obstruction. So can actually help avoid complete bowel obstruction. And yeah, so an ileus, yep, yeah, exactly, yep. Anything that causes, like, the problem is not a mechanical obstruction, but a dysmotility issue, but also partial bowel obstruction. So caused by a mechanical obstruction, but not fully obstructed. It can actually keep things moving, sometimes through the little bit of space that you have left. Once it becomes complete, obviously we don't use metoclopramide because of the possibility of actually making things worse, making pain worse, and also I think the idea, I don't know if it's more than a theoretical risk, but there is at least a theoretical risk of perforation caused by using metoclopramide in complete bowel obstruction. Apart from that, there's not actually a lot of clear data that tells us one antiemetic is better than another, although most guidelines suggest haloperidol over everything else. And I'm not sure what the reason is, or if there even is one. Most sources I looked at also said consider phenothiazines, like prochlorperazine, which is Stemetil, and others like things that I don't really ever use for nausea anyway. And we don't tend to use Stemetil very much here either, but those are recommended. I didn't see anywhere that it ever mentioned ondansetron, which kind of makes sense, I guess, with the constipating effect of ondansetron. But so that's antiemetics. Corticosteroids are routinely used, although again, there's not much evidence for this. The studies that are out there show a trend towards a decrease in symptoms, but nothing considered significant, and no difference in mortality. So the mechanism of action isn't quite really even understood. It's like there's likely a separate antiemetic and anti-inflammatory effects. So the anti-inflammatory increasing edema and hopefully relieving the pressure. The dose range suggested is, everywhere I looked, was 6 to 16 milligrams a day in divided doses. And studies have found sort of a minimal risk of significant adverse effects, at least over the short period of time that tends to be used for. The big sort of section here is really the anti-secretory agents. So anti-secretory agents actually include the antacid type medications that I don't tend to think of right off the bat as anti-secretory, but they certainly are. So proton pump inhibitors and histamine antagonists like ranitidine both decrease preoperative gastric secretions in studies they've done on that. Somehow ranitidine has been found to be more potent in that. It was actually David Currow, the same guy that was the PI on the octreotide study that we're going to talk about later, that found octreotide not to be effective. He actually did a study and did that study on ranitidine being more effective than proton pump inhibitors, and there's a whole list of different proton pump inhibitors that they looked at. So, there is evidence for ranitidine and PPIs. So the anticholinergic agents are also anti-secretory, and so that would include buscopan and glycopyrrolate, as well as scopolamine. And they apparently have certainly buscopan has the advantage of also decreasing muscle spasm, so decreasing the colicky pain that we want to get rid of. And then there's the somatostatin analogs. So these medications work in multiple ways. They inhibit the release of gastrin, CCK, which is cholecystokinin, I think, something like that, VIP and pancreatic enzymes, and that results in the decrease of bowel secretions. They also decrease neurotransmission in the nerves of the gastrointestinal tract, which helps decrease pain and cramping. That also decreases peristalsis. They decrease the splanchnic blood flow, which is, as we said before, can actually cause a whole bunch of problems, including increased edema in the bowel wall, also increasing secretions in the bowel wall, and also resulting in some of the sort of distant effects of malignant bowel obstruction on other organs due to hypovolemia. So they also cause increased absorption of fluids and decreased bile flow, all of which sort of helps improve the situation. Octreotide, the short-acting octreotide, is probably the most common one that's used. Recommended dose is 100 to 600 micrograms a day in divided doses. There's the long-acting octreotide, the octreotide LAR, which is usually given at a dose of 30 milligrams subcutaneously every 4 weeks. And that there is some evidence that's effective as well at doing the same thing. There's less evidence for that. This does require, I didn't know this, whenever I've used this before, I did not know this, but it is not, the systemic absorption of the LAR is actually quite unreliable during the first 2 weeks after it's given. So you actually still have to give the short-acting dose daily for the first 2 weeks. I didn't realize that, which may be why. I do remember one patient in particular was very unhappy when I did that to him. He thought the LAR gave him more cramps and nausea, but I expect it just wasn't working. So then there's something called lanreotide, which is another, it's a different somatostatin analog. It's in a long-acting form, again, administered monthly. There's some evidence that it works, but there hasn't been as much much work done on that. So just to go over some of the evidence, not too much detail, there have been some uncontrolled studies that were quite promising for decreasing nausea and vomiting, as well as GI secretions by somatostatin analogs. Controlled studies have been less convincing. In one study, there was less early nausea compared to buscopan, but no difference in pain. For the LAR and the lanreotide that have been studied, the results have not been spectacular compared to placebo. So according to the Oxford text, which I know that chapter was written quite a long time ago, 2 to 3 out of the largest studies done at that time showed that the somatostatin analog looked at did not show any benefit over placebo. For everything, multiple things. So the randomized control trial by Curl that was attached to the email I sent you guys and is in the Dropbox was done in 2015. They compared a subcutaneous infusion of octreotide of 600 micrograms per 24 hours plus standard treatment, which included parenteral dexamethasone 8 milligrams per day and ranitidine 200 milligrams a day, as well as parenteral hydration to standard therapy alone. The patients that they looked at were patients with advanced cancer presenting with vomiting due to malignant bowel obstruction with no immediate option for surgery or any anti-cancer treatment. So relatively specific group, but probably very similar to the people that we would see. They were also given parenteral opioids, buscopan, and haloperidol as needed for appropriate symptoms. So this study showed no difference for the primary outcome of the study, and that primary outcome was the number of days free of vomiting and the number of subjects who were free of vomiting for over 72 hours. So it didn't sort of make more people nausea-free than without glycopyrrolate, or sorry, without octreotide. One of the secondary outcomes was looking at the mean number of vomiting episodes over the study period, and the octreotide arm did have a lower mean number of vomiting episodes. So people reported vomiting less often. However, they didn't feel any different about their situation. Their daily outlook was just as grim or just as good. It actually improved in both arms, but was no better in the octreotide arm. The presence of nausea was the same. The intensity of nausea was the same. The pain intensity was the same. and survival was the same in both groups. So people didn't actually, I thought that was kind of an important one. They didn't actually feel any better. They just seemed to vomit less often. They didn't even feel that their nausea was any better. It just seemed to happen less often. So interestingly, the octreotide arm actually was significantly more likely to receive buscopan than in the group that didn't get octreotide. So not sure why that is, unless somehow octreotide is causing or contributing to the peristalsis that causes that colicky pain. So the conclusion of the study was, particularly considering the cost of octreotide, there's really no incremental value from octreotide. So using, I think one thing I took from this study is that we should maybe be trying ranitidine. Despite that study, the up-to-date chapter, which is the only thing I read that was written after this study came out, it still recommends using octreotide and still talks about, there being significant evidence for using octreotide. So it's certainly not, people haven't stopped using it. Not everyone has, most people haven't stopped using it because of this study. So, and I guess even before that, there was a significant amount of evidence that failed to show a significant improvement with octreotide for many different things. So I did try and see if I could find, because we've been talking about, when do you stop? When you stop using octreotide, you just keep using it, even after the, if you're malignant bowel obstruction episode seems to end, and I couldn't find anything that addressed that. I don't know if there is any evidence out there. My guess is that generally it would be stopped, but I don't know. I couldn't find anything that suggested. Yeah. So, all right. So surgical intervention. So I'm gonna
Julia?
Yeah.
Sorry to interrupt. This is more curious rather than thinking it might be on the exam, but I was just wondering, did you come across any evidence that relates to the anticholinergic or antispasmodic activity? Has that been studied to the same degree as the anti-secretories?
Of octreotide?
No, of like buscopan versus, that's the one I use all the time. But as you said, I guess theoretically you could use scopolamine or glyco.
You use it as an anti-secretory agent, you mean?
Sorry, antispasmodic. I'm just curious, have studies been shown, difference in pain, difference in nausea?
Not that I saw, not for buscopan. I'm sure they're out there, but I don't think there's as much controversy over using. There's a lot of controversy, but octreotide seems to be something people are focused on.
Well, it's expensive, I guess, right?
Yeah.
Whereas the antispasmodics are cheap, so.
Yes, and I think that from what I was reading, the antispasmodics can act as anti-secretory agents as well. So kind of makes you wonder, maybe we should try without the octreotide and just use their buscopan, especially in people with colicky pain.
Okay, thanks. I'm just curious. We talk about the evidence of DEX and anti-secretories a fair amount, I guess, but I never heard anyone talk about evidence for the antispasmodics.
Yeah, no, I didn't see any, but I'm sure there's some out there, but I didn't find it.
Thanks.
Yeah, no problem. So surgical intervention, like I said, I'm just gonna, because I'm not a surgeon, I don't like surgery, and I don't really understand what it is they do, because it's all in 3 dimensions, and that's one too many for me. But it did actually make sense reading it in a very simple form. So the options for surgery include complete resection of the mass, operative bypass of the mass, lysis of adhesions, creation of a diverting stoma, or any combination of any of those things above that would work for the person's particular anatomy and the location of their tumor. So whatever the surgeon thinks might actually work for that patient, then they would do. So that's all I'm going to say about what they actually do in the surgeries. How you sort of sort out whether or not people are good candidates for surgery. It depends, obviously, first of all, on what the patient's goals and wishes are. If they don't want to have surgery, then the conversation, as long as they understand what their options are, the conversation should probably can end there. The patient may or may not have any symptoms that the surgeon will think will actually benefit from a surgical intervention and actually result in improvement in quality of life. Just because someone has a bowel obstruction doesn't mean that they're going to benefit from surgery for it, even if they could tolerate the surgery. So, and then of course we also have to consider the patient's comorbidities and functional status, which will make them a better or worse candidate for surgery and what might happen as a result of surgery. So there are a lot of studies. It depends on who's writing the study, the paper that you're reading. But as a surgeon writing it, they might feel a little differently. But a lot of studies that indicate that survival is not actually different in patients who have surgery versus patients who don't. That does depend on other things, including tumor type, tumor grade, where it's spread, how long it's been from the first presentation of their cancer, and whether or not there's the possibility of further anti-cancer treatments for that patient. I think that really kind of speaks to how sick they are with their cancer. There's no universally accepted guidelines on how to figure out who would be a good candidate for surgery, but there are a lot of factors that people look at when they are thinking about this. So patients with an extreme tumor burden, so bulky abdominal carcinomatosis, parenchymal liver metastases, large volume ascites, other organ impairment, multiple sites of obstruction. Those are all things that point to a large tumor burden and make someone not a good candidate. Other factors include older patients. They were talking about elderly, and then they said they defined that as over 65, which now I'm 50. That doesn't actually sound that elderly to me, but low albumin is mentioned time and time again as being a poor prognostic factor for surgery, poor psychological health or poor social support, concurrent illness, comorbidities, poor functional status, a complete small bowel obstruction is a poor prognostic factor as opposed to either partial small bowel or a complete large bowel obstruction, non-gynecological cancer, and a normal white cell count. Those are all factors that should sort of point you towards not being such a good candidate. So then endoscopic intervention. There's really the two endoscopic interventions that usually get talked about are stenting and venting gastrostomy, and I've kind of already talked about that. So I'm just going to really talk about stents. So these can be considered, particularly in patients who aren't candidates for surgical intervention but have significant symptoms, and they are involving self-expanding metal stents. That's what we're talking about. There's fairly extensive coverage of this in the Oxford text. I think it was written by somebody who actually does this because they talked in detail about how they actually do it, which I'm never going to do that. So I didn't sort of get into that. A couple of important points though are that you can only put stents that you can reach with a scope. So some places in the small bowel you can't reach them, so can't have stents. They're often used so they're probably most commonly used, especially in our area, with the more proximal obstructions, including gastric outlet, duodenal, and proximal jejunal obstructions that you can reach with a gastroscope. They use special scopes that have a big, I picture it as a big hole in the middle that they can stick the stent down through. So there is some evidence for improving symptoms from goo which is gastric outlet obstruction. I had to write that at least a couple of times. So improvements of symptoms, return of ability to eat, and it actually compares favorably to surgery for certain things, including shortening hospital stay, getting back to eating more quickly, better symptom profile, and lower peri-procedural mortality. But overall survival is shorter with stenting than it is with surgery, which I think can possibly be explained by the fact that the people getting stenting are people who can't get surgery, who are probably sicker to start with. So the numbers that came up were mean survival time from stenting for proximal obstruction was 105 days compared to 165 days for people getting gastrojejunectomy. So the complications associated with this are the main complication is considered delayed stent failure, and that occurs in 18% of cases. And that can happen, that can be due to food getting stuck in the stent, the tumor just growing over the stent, or the stent migrating. The most common is actually food impaction than overgrowth. Stent migration is less common, which it seems weird to me. I feel like I hear about that all the time, but some people actually require re-intervention, so you can add new stents to the previous stent, replace the old stent, or something I wasn't that familiar with is actually going in and doing some tumor ablation with APC, which is, I can never remember what that stands for, but or laser. That's going to bother me now. Anyway, they do it. I think they do it to ulcers too, don't they? I think so. Anyway, it doesn't matter. I'll look it up. So it's less likely to be helpful if the patient has peritoneal carcinomatosis or multiple sites of obstruction, and that's likely just because you can't probably stent everywhere. Yes, it's obviously a weird thing. Sounds like an alien thing. Argon plasma coagulation, that's what the APC stands for. So colorectal obstructions can also be treated with stents. I think whenever that's come up in our area, the surgeons always said, no, that wouldn't work. But it can help. It can help in a similar way, similar relief of symptoms, similarly decreased hospital stays compared to surgery, and also fewer complications compared to surgery. There is a small risk of less than 4% of macroperforation at the time of the stent placement, and the risk of death due to the procedure is 0.5%. There is a low risk of reobstruction, so 90% remain obstruction-free until death. The long-term complication rate, though, is almost 25%. I think 9% of people get perforation. There's a higher percent that get reoccluded, which doesn't make any sense. But anyway, and the stent can migrate. And they mention a very low rectal obstruction should not be stented. That would result in loss of bowel continence. So some kind of diverting ostomy is preferred for them. So that's the what I wanted to say about surgical options. And then there's just a short section on recurrent episodes, on what to do with those. There is a good sort of section on how to manage recurrent bowel obstruction or at home. That was kind of the focus in the case-based manual. So some of this comes out of that, and not all of it. So once somebody gets through an episode of malignant bowel obstruction, it's really important to try and prevent, do what you can to prevent it happening again. So adequate hydration, using metoclopramide for the prokinetic action, doing everything you can to maintain daily soft bowel movements, preferring osmotic laxatives like PEG, rectal suppositories, PRN, and avoiding high enemas. And then promoting a soft or liquid low residue diet, so low fiber, soft diet, to try and try and avoid reobstruction for as long as possible. It's important to have a treatment plan for future episodes. And this is something I've tried to do multiple times in the past and with limited success, to be honest. So anybody you expect might be at any risk of reobstructing, it's important to have, especially at home, all the parenteral medications that you might need in place, which is maybe a good argument against octreotide, because paying for octreotide that you may never use is kind of a hard sell. And then orders for these to be used as soon as cramps, distension, nausea, or vomiting occur. I actually did this recently for a lady, and they started, as soon as she got a bit constipated, they started her on 16 milligrams a day of dexamethasone, and she promptly became extremely delirious. Did not do well with the steroids. Ended up in hospital. Probably, I wouldn't be surprised if she actually died sooner because of the delirium associated with that whole episode. Anyway, it's my dream to one day for us to have an order set for people who are at risk of bowel obstruction, used at home, and to have that used properly. Dream, one of my dreams. Yeah. So then, unresolved incomplete bowel obstruction, which is how sometimes people will die who get bowel obstruction. Managing that at home requires adequate coordinated resources in the home setting, including 24/7 access to physician visit nurses. The goal is elimination of nausea, reduction of vomiting episodes to less than 2 a week. That's rather than resolution of obstruction at that point. The patient should be offered sips and soft foods as tolerated. Some patients actually prefer to eat and then vomit after eating if eating is really important to them. I didn't put anything in here about the venting gastrostomy, but I know we have a patient currently who's just actually discharged home, I think today, with her venting gastrostomy and her resolved bowel obstruction, in hopes that what's that? No, something is something. Well, McConaughey, yeah. She's off home today with her venting gastrostomy. So I mean that's something that could maybe be thrown into the mix, venting gastrostomy, to help with future episodes at home, because YouTube again is not going to work for most people at home. Meticulous mouth care, very important. Discussion of goals of care, including what to do about hydration. And one of the points that was made was as people become more dehydrated, they're going to be more at risk, higher risk of opioid toxicity from their quite necessary opioids. So that's something to keep in mind as well. Supportive counseling, obviously important, and as always, for intractable severe distress, palliative sedation can be a solution. And that's kind of all I put together from malignant bowel obstruction. I don't know if anybody has anything they want to add or things I missed that we probably might need to know. There's only 10 pages. I'm excited. Yeah. Well, I don't know, Chris, if you ever looked at the Cachexia, I think it was like 40 pages. It felt like it anyway. It was horrible.
That's probably where I should go next. I feel like I know nothing about anorexia, cachexia syndrome, and all the inflammatory pathways.
Yeah, and the end result is we don't really know.
And we have very little to manage it with. It's very, it's like neurology in general.
Yes, yeah. So, so as far as next week, Jesse, are you doing? Jeff's going to do liver disease, so I guess the rest of us can maybe just pick something and make sure we're not overlapping, and send out to each other what we might want to do.
If it's okay if I just check with you now, I'm just looking at the list on Dropbox. Am I correct in seeing that opioids specifically haven't really been covered? And I guess what I'm wondering is, I've done some notes already, and I'd be happy to firm them up and present on things like,
That'd be awesome. Yeah. Yeah.
you know, the differences between some of the secondary receptor effects that they have,
Yeah.
difference of metabolism.
That would be awesome. Yeah, I think we did methadone specifically, and Robin did like just the pain pathway, but not specifically opioids. So
Just
that'd be awesome.
opioid pharmacology kind of.
Yeah.
Okay.
Good. Yeah. Yeah, I know when I was going through, I was thinking, oh, I should probably be talking about constipation. I don't want to talk about constipation, but I don't know if there's anything any of us actually don't know about patients that we don't want to know. But anyway, I'll see what I can find.
They'll write some riveting exam questions
Yes.
on constipation,
Yes.
I'm sure.
Yeah. Oh, yeah. Yeah. Yeah, and I think Megan's had to go off, but yeah. All right. So maybe I'll think of something and send it out and to everyone and go from there.
That was great. Thanks so much.
And hope Robin thinks it's not a terrible idea.
Yeah.
Yeah. Anyway. All right. Great. Well, thank you.
Okay. Thank you.
Next
See you
week.
later.
All right.
See you.
Bye. Yeah.